So thank you very much. Thank you everyone for being here. Although I am an organizer, I'm actually surprised of the quality actually that we were able to of presenters and everyone. And I think it's very important that we start looking a little bit more deeper and scientifically on these very interesting but also very difficult topic. So I'm also very glad to co-chair this session with Dr. Morgan Bomsel. Okay, so these are my disclaimers here. So I will do a very quick overview of what we have learned. This will be a top-level review because there will be, I think it will be much more interesting than my talk, the talks that will come right afterwards. So very briefly, so the first thing that we have learned is that long COVID is a multisystemic post-viral disease that is affecting many organs in the body, almost every organ in the body, and going from the heart, lungs, immune system, neurological system, blood vessels, etc. And this is already, so this is a real disease. And the first thing we learned from this early study in 2022 is that long COVID is not going away. There's politicians and also people who make decisions on healthcare systems are wishing that this would go away, that this is something that would happen just for a while, but that's not true. And in this very interesting and very good work, it's already showing how many symptoms, but also the impact of all these symptoms actually improves, maybe initially, but then it goes up again. Showing that, well, personal activities, professional activities, social activities, morale, family, relationship with caregivers is getting worse over the time, and this is not living. So we have to do something. For the first thing that we focused a lot is in showing there is actual real organ damage, and I will not go into details. It's only 10 minutes, but I will just show you a few examples. So first is that in this review, in this paper from the Veterans Affairs group in the U.S., you can see how there's the risks of incident composite cardiovascular, but also neurological, gastrointestinal outcomes are increased. They are also, they come with a lot of disability. And yes, they are more likely to be seen in severely affected patients, but less and less, we're seeing less and less of those patients, luckily, thanks to vaccines. But if you instead, we're seeing a lot of patients having a relatively mild disease. And of course, there is also an increased risk of all these outcomes in patients with mild disease. And that explains why in our clinics, we are seeing mostly people with low, with a relatively mild acute disease. So the maths actually match. One example from our unit, we evaluated a number of patients, so up to 27% of our patients had chest pain, anginal chest pain. And when you test, when you actually do MRIs and you do adenosine MRIs, what you do see is that at least half of them have, and numbers were small, there are only 10, but the cohort is now much larger, and more or less we keep the same numbers. Half of them actually have subendocardial ischemia with normal coronary arteries. These are young women without other cardiovascular risk factors. The coronary arteries are normal, and still you see myocardial ischemia. Of course, you can find also myocarditis, because we all know that SARS-CoV-2 causes myocarditis. And yes, in a number of patients, you also have normal findings. But so it is the burden of subendocardial ischemia is pretty high. Of course, then another aspect that it's an objective measurement is the inappropriate sinus tachycardia. In this case, we evaluated in our long COVID unit led by Lourdes Mateo and others here. We found that inappropriate sinus tachycardia was present in about 20% of prospective long COVID subjects. And here you can see clear evidence. So this is not just something that patients are making up. Then we recently published a paper led by Gemma Llados, who's also here, showing that also the vagus nerve, for example, is affected. There's vagus nerve dysfunction in many different aspects. You can do ultrasounds in the neck ultrasounds in the vagus nerve. We're not saying that this is the only reason. We're not saying that this is the only factor. And of course, this paper is a cherry-picking exercise. So we pre-selected patients that were enriched in the possibility of having the vagus nerve altered. But we do see a number of structural but also functional changes affecting the vagus nerve, but also the phrenic nerves, for example. So one interesting aspect here is that when you look at patients with dyspnea and normal X-rays, for example, what you see is reductions in the maximum inspiratory and expiratory pressure. That is clearly a suggestion that the phrenic nerve and maybe other nerves are also affected. And we could go on, and I think that's not the point of this talk. So first, then, the first message is there's organ damage. This is a real disease, and I think that we need to highlight that, because many of our colleagues don't understand why we work in long COVID. And just because it's difficult, we should not stop there. And then in terms of mechanisms, and also will be a top-level review, this is a classical summary by Hannah Davis. So on one hand, we have immune dysregulation. We've seen that yesterday. We'll see more about this, possibly related with persistent viral replication to some extent and reactivation of reservoirs. Yesterday, there was a very nice paper from France showing that the macrophages, at least in early phases of COVID, can become at least one source of potential reservoirs. Also, another reservoir could be the gut, also the fat. So we're now everyone in the process of digging deeper and finding, looking at the different tissues and seeing what happens there. Autoimmunity is also very important, and immune priming, and we'll see that afterwards. And I think we are very lucky to have Dr. Theresia Pretorius here that will tell us more about blood clotting and endothelial abnormalities. Their group has also done amazing studies here. Finally, dysfunctional neurological signaling. So as I said before, the vagus nerve, phrenic nerve, and also central nervous system alterations. This paper is very, very nice by Zollner, also from 2022, showing that during acute COVID, actually SARS-CoV-2 uses AC2 receptors. AC2 are all over the place, and it's actually not the lungs, necessarily the cells in the lungs that are the ones with higher expression. Enterocytes can become infected very early and relatively easily. So it seems that at least in several patients, SARS-CoV-2 can remain in the gut, and in post-acute COVID-19. And this is data from 7 months after acute infection, but now there's data looking beyond that. You can detect antigen persistence. There's still a lot of discussion whether that's a live virus or not. It's a virus that's replicating or not, but at least the antigen is there. And in this paper, the presence of the antigen was clearly associated with fatigue, memorial issues, loss of smell, and so on and so forth. As I said, systemic endotheliopathy. I will not go into details on the mechanisms, but what is really worrying also is this idea that into suspective angiogenesis. So actually, because of chronic ischemia and in small vasa, the vasa can then grow and then can become create obstructions that might be very difficult to solve over time. And here you have an electron microscopy of let's say a normal alveoli on the left and one on the right with endosuspective endotheliopathy. So endotheliopathy is very important. Of course, all the effects on the CNS, going from neuroinflammation, neuronal and glial dysregulation, dysfunction of neural circuits, cognitive impairment, but also the direct effect of even the SARS-CoV-2 MPRO is something that is very, very, very important. Autoimmunity is there. SARS-CoV-2 infection triggers autoimmunity. The issue with autoimmunity is that autoimmune antibodies actually target many different antigens around the world, around the body. So it will become a little bit difficult from my point of view now to turn this into an actionable test, but I think that we can discuss that later on. In this paper by the Yale's group, actually, when they did a tour de force looking at many different aspects, and I'm sorry the slides were moved here. What I wanted to show is that actually low cortisolemia levels are also affected, and actually they were one of the highest predictors of long COVID-2. And two more things that have come up. Mitochondrial dysfunction. Dr. Appelman will be telling us more at the end of this session. The mitochondria is actually altered by SARS-CoV-2 infection, and most recently we have this paper from Penn showing how serotonin reduction could actually be one of the mechanisms linking the different aspects that we've seen before, going from interferon responses to the vagus nerve. And finally, of course, it's always the microbiota. So the microbiota is altered very early during the SARS-CoV-2 disease. We know that these changes remain over time, and also they are able to cluster patients in, and more will have to be done in terms of the microbiota. So in conclusions, there's a simultaneous multifaceted pathogenic mechanisms, including viral persistence, immune dysregulation, autoimmunity, endocrine parameters, endotheliopathy, gut dysbiosis, and vagus nerve dysfunction. Let me finish by thanking the group led by Lourdes Mateo and also Marta Massanella, and also our collaborators in both with patients, the COVID persistent, and also Oxford. Thanks a lot.